Okay, folks, good evening. This is Mary Sue Lanigan. I'm the Executive Director of the Michigan Parkinson Foundation, and I welcome you to our Tuesday evening program. Tonight's topic is deep brain stimulation right for you? Our presenter is Dr. Adam Coleman. He is the Medical Director at Beaumont's Movement Disorder Program. He sees patients at the Beaumont Royal Oak. And we are delighted to have him. I think you're going to find this to be a very interesting and informative program. I'm going to mute everyone, and you are welcome to put questions in the chat box on my screen. It's at the bottom of your screen. Or when the program is over with, you can unmute yourself and ask the questions. So, Dr. Coleman.
All right. Well, good evening,
Welcome.
everybody. Thanks for, I know it's sunny and getting warm outside. Thank you for spending a little bit of your evening with us. So got a few slides to share with you here regarding Parkinson's disease, as well as then deep brain stimulation and kind of other treatment options available for Parkinson's disease. Obviously, as Mary Sue said, that as things come up along the way, if you have any questions, don't hesitate to post them up in the chat. But I imagine this will probably take somewhere in the neighborhood of about 25 minutes to get through, and then we'll have some time to answer questions after the fact. So, just so I can see. Okay. So we'll start, fairly simply with something that I think everybody, is pretty familiar with. But what is, Parkinson's disease? Well, Parkinson's disease is a progressive chronic condition that affects, an important neurochemical in the brain called dopamine. Dopamine serves a number of important brain functions, from mood and behavior, reward systems. But one of the main systems that it is involved with is planning and coordinating our movements. And so when dopamine becomes insufficient in the brain, can we mute there?
I got it.
Okay, thank you. When dopamine becomes insufficient in the brain, then we can see a number of symptoms arise, and we'll talk about that in a moment. This is a condition that affects about 1% of the population over the age of 55, which may seem like a small number, but it actually makes it fairly common. It is the second most common neurodegenerative disease behind Alzheimer's disease. And affects over 1 million Americans and about 10 million people worldwide. The exact cause of Parkinson's disease is unknown. The more we understand about it, the more we're understanding that this is a very heterogeneous condition. There are many different causes for the thing that we currently define as being Parkinson's disease. Kind of what we understand of being the final common pathway is that there is a normal protein that begins to accumulate in abnormal amounts called alpha-synuclein. And when it begins to aggregate and clump in abnormal ways within the brain, then it becomes toxic. And then that toxic nature begins to damage and kill off neurons, specifically dopamine producing neurons. There you go. So symptoms of Parkinson's disease, we often associate it very strongly with a condition that causes tremor or other movement problems. And that's really only half the story. So, the kind of what we refer to as the motor symptoms of Parkinson's disease include tremor, but may not include tremor. About a third of people with Parkinson's disease don't have tremor and may never have tremor. The things that you have to have are this thing that we call bradykinesia, which is literally kind of the slowness of movement, the tendency for movements to get smaller with repetition, and that manifests itself in a number of ways, from shuffling of the feet to, handwriting that gets small and illegible, to difficulty with fastening buttons or tying shoes, or doing a number of other tasks that require some manual dexterity. The other main feature of Parkinson's disease is rigidity, which is this resistance, this increase in muscle tone, this resistance to passive movement in the arms and the legs, and postural instability. When we learn about Parkinsonism in medical school, we call 4 cardinal signs include tremor, rigidity, bradykinesia, and postural instability. Postural instability in Parkinson's disease is one that I tend to kind of leave off the list very often, because especially when people are beginning to experience symptoms at the onset of what we kind of end up diagnosing as Parkinson's disease, significant postural instability really shouldn't be a major finding. And so that is just kind of an overview of some of the movement, kind of what we call the motor symptoms of Parkinson's disease. There are certainly a number of other symptoms that go along with Parkinson's disease that are associated and that we refer to as non-motor symptoms. And those may include a decreased sense of smell, a tendency towards constipation, depression and anxiety we see in increasing amounts in persons who have Parkinson's disease. Which is interesting. A lot of people feel as though, well, that's just a reactive thing. Of course, if I had been diagnosed with Parkinson's disease, I might be depressed or anxious. But we know that those changes in mood precede any other movement symptoms or diagnosis of Parkinson's, and so is as much a symptom of the disease, as much a symptom of Parkinson's as a tremor might be. Pain is another non-motor symptom. This is something that's fairly non-specific and can present itself in many different ways. And so, really kind of throws people a little bit for a loop very often. Insomnia and other sleep disturbances, specifically the tendency to have very vivid dreams, the acting out of dreams, kind of dream enactment behavior, which is kind of punching, kicking, flailing around in that dream state, when normally our brain kind of paralyzes the body, so we don't have the ability to do that. That ability becomes dysfunctional in Parkinson's disease and can predate tremor, stiffness, slowness by 5, 10, 15, 20 years. And fatigue is another big one that we run into incredibly often. And this is, again, just an abbreviated list that, it's beyond the scope of the talk to kind of really go into all the different things that can, from a non-motor perspective in the setting of Parkinson's disease. But certainly this, to highlight the idea that it is more than just the tremor, stiffness, and slowness that we think of very often. So what do we do in terms of treatment options for Parkinson's disease? Well, this is something that we want to make sure that we tailor from person to person, from patient to patient. Everybody's needs and symptoms are going to be a little bit different and therefore require a little bit of a different approach. Those, we'll hit upon some common themes here. Exercise is a big one. I stress exercise with almost all of my patients, if not all of my patients. The effectiveness of aerobic exercise, kind of getting up, moving around, the kind of high repetition, low resistance exercise and workout is really been well proven. Things that have become very popular or are things like Rock City Boxing or other boxing programs. There's dance for Parkinson's, there's Tai Chi, there's yoga. But my advice for people when it comes to exercise is to find something that you, first and foremost, find something that you like. Find something that you can see yourself doing, several times per week for the long term. Because if you pick something just because someone says that, oh, this is something that's good for Parkinson's disease, and you hate it, you're not going to do it. And it's really, important that there is, the long-term maintenance of this that pays off dividends in the future in terms of maintaining function and over the long term in the setting of PD. Medications is a topic that is becoming, ever more complicated as time goes on, and complex with new entrants to the arena and more options to choose from. However, the kind of gold standard, and as one of my mentors always likes to say, the kind of platinum standard is levodopa, also known as Sinemet, and has been around for over 50 years at this point, and remains the kind of most potent and effective medication for the reduction of the majority of symptoms of Parkinson's, the motor symptoms of Parkinson's, I should say, namely the bradykinesia and rigidity. In fact, the responsiveness and improvement of Parkinson's symptoms to levodopa is considered essentially a requirement for diagnosis, more or less. And then we kind of get into some of these other surgical options. There was ablative surgeries that we refer to as pallidotomy or thalamotomy. These are surgical procedures that began, I guess we're going on 90, almost 100 years ago. It really kind of had their heyday in the 1930s, 1940s, and around that time, where we realized that going into the brain and heating up an area of the brain within the globus pallidus, hence pallidotomy, or within an area of the thalamus, therefore thalamotomy, can improve symptoms of tremor, stiffness, slowness, to a fairly significant degree. And there was a little bit of a drop off in the performance of these types of procedures for quite a while after we discovered levodopa. And then we began to discover that there were some complications that we ran into with the medical treatment of Parkinson's. And so a lot of these surgical options have reemerged, first with deep brain stimulation, and then these ablative surgeries are making a comeback to some degree with a surgical technique that we refer to as focused ultrasound. And then lastly here, in terms of other treatment options, is neurorehabilitation. This includes physical therapy, occupational therapy, speech therapy. And this is something that I would argue has a place to be employed in the setting and treatment of Parkinson's disease from essentially the time people are diagnosed, through the mild, moderate, and advanced stages of Parkinson's disease. So, the main thrust of today was to kind of touch upon deep brain stimulation as a potential treatment option for Parkinson's. And so, what is deep brain stimulation? Well, this is a surgical procedure that is done with the cooperation of both a neurologist and a neurosurgeon, and involves two stages. The first stage is where there is the implantation of this lead, this electrode, into the brain, into one of generally two targets, and we'll talk about that in a moment. But those targets would be the thalamus or the globus, subthalamus, and the globus pallidus, and is something that delivers a small amount of pulsatile high-frequency electrical stimulation via this rechargeable or non-rechargeable battery, which is kind of the battery and computer all in one. And by delivering this small amount of electricity, it is able to restore a nearly normal, or somewhat much more close, what much more closely resembles normal output from dysfunctional brain circuits that are affected by the reduction or absence of the dopaminergic, the dopamine input to those circuits. And so this is done in two stages, and there's a video at ddsme.com that's on Boston Scientific's website that can explain that also a little bit further. And so again, that the surgery is done in two parts. The first part is the actual implantation of this electrode, and that is done in one of two ways, either by guidance from intraoperative MRI or using a technology that we call microelectrode recording, which listens to the way that brain cells are firing and responding to different stimuli to target and locate the correct area of the brain. And then that is done in the OR, usually requires an overnight hospital stay. And then 2 weeks later, you go back into the operating room where there is this extension wire that is placed underneath the skin of the scalp and underneath the skin through the neck and connected to this battery. Usually that is placed underneath the collarbone in the chest, either on the left side or on the right side, but can be placed in a number of different locations. Alternatives are, that I've seen include the abdomen. There's been one or two that have had it placed in their back. And so there are several options based on patients' needs. So the reason why we would consider this surgery is because we, as I alluded to before, we kind of run into some problems with the use of oral medications in the treatment of Parkinson's. We normally get this very robust response to levodopa, where we can nearly erase most of the symptoms that people are experiencing in the early stages of Parkinson's disease, and people enjoy sustained symptomatic relief throughout the day. Very often, doctors like myself will ask people, well, do you feel the medication kick in? Do you feel it wear off? And for a long period of time, a number of my patients will say, you asked me that question. I have no idea what you mean. I never feel that. I wouldn't even know how to answer that type of a question. And that is very common to happen, especially for the first 3 to 5 years after diagnosis, that we get this very robust, sustained response without any problems. And that oftentimes for many people begins to break down in the moderate to advanced stages of Parkinson's disease. And what happens is there's continued loss of your own native dopamine producing cells. They become more reliant on the medication to alleviate symptoms. And what happens here is that over time, people will begin to take medication. You feel, oh, the tremor's gone, and my stiffness is better. I can move a little bit more quickly. My walking is maybe a little bit faster. And then after an hour, 45 minutes or so, some additional movement that's involuntary kind of enters the picture, something that we refer to as dyskinesia. Dyskinesia are these kind of dance-like twisting, turning type of movements of the head and neck, or of maybe a hand, or twisting, rolling of an ankle or both legs. And that may last and be relatively mild, or even unnoticed outside of maybe of friends or family members who would say, why are you moving that way? And patients will say, I don't know what you're talking about. I guess, yeah, you're right. My ankle is turning on me. And then that goes away. And so we, have a little bit of this, take medication, run into a little bit of extra movement. Maybe you begin to realize like, oh yeah, that's right. If I don't take my medication right at that, 5-hour mark, I'm feeling it wear off. I feel my tremor comes back. I'm feeling a little bit stiffer. I need to make sure I take my medication right on time, or maybe I need to take it a little bit earlier than I was taking it before. And then time, more time marches on, and that responsiveness becomes even less and less predictable. The dyskinesia may become more pronounced. The responsiveness to taking medication and having that alleviate symptoms, and it maybe still works, and you still get that some good on time, but then you have instances where you'll take a dose and nothing happens, and or it wears off early, or becomes really erratic, really unpredictable. And we have employed a number of medications and other pharmacologic strategies to try to address those symptoms, but to quite frankly, very often we're trying to, by continuing to change medications, it's almost like you're trying to shove a square peg into a round hole, and it poses a challenge for some additional or better therapeutics or more advanced therapeutics. And so that when people begin to develop these instances of what we call motor fluctuation, which is that phenomenon of feeling the medication kick in, then feeling it wear off before the next dose is due, as well as the motor complications of dyskinesia, while still having good responsiveness to medication, is kind of that window of opportunity for DBS. Medication still works really well, but we're running into some of those problems. Before that, symptoms are mild. 3 doses a day of Sinemet takes care of everything. Really not the place for DBS to enter the picture quite yet. And in the most advanced of stages, there are so many other things going on, or the responsiveness of medication declines because of the advanced degeneration that occurs in Parkinson's disease, that DBS therapy is either contraindicated or is just not going to provide the relief that we'd be looking for. So basically, the way that we think about, or at least part of the way, the rule of thumb that I think about DBS is that electricity is almost like it's providing electrical Sinemet to the brain. That as a general rule, the things that get better with Sinemet will get better with DBS. And the things that tend not to get better with levodopa tend not to get better with DBS. The one major exception there is with tremor. A lot of people will have really significant refractory tremor that does not respond to medications, and DBS can manage that with a much more powerful responsiveness, a much more powerful influence on tremor than most of our medications typically are able to. So for people who may be a potential candidate for DBS, is we have to have a confirmed diagnosis of Parkinson's disease, which traditionally has meant that you've had symptoms for 4 to 5 years, which allows for kind of some of these more rarer, atypical syndromes to have presented themselves over that period of time. So we can be, confident that when you have tremor, stiffness, and slowness, that it is truly, in fact, Parkinson's disease. Need to be responsive to dopaminergic therapy. As I said, we expect the best response that you can get from levodopa is essentially what we use as a benchmark for responsiveness to DBS, and that we have some of these on-off fluctuations or dyskinesia that are not easily controlled with a very simple adjustments to medications. People who are outside of the window and no longer DBS candidates would be those who have a diagnosis of dementia. The reason for that is that the implantation of those electrodes into the brain can break up enough of those connections, and that the stimulation can kind of throw people off enough, that the stress of surgery can throw people off enough that it can cause further cognitive decline. And so it's a thing that we really don't do outside of really kind of exceptional kind of palliative types of cases. And any other medical contraindications that might prevent surgery, or kind of those latest stages of Parkinson's disease. So I kind of mentioned a number of these things already, but the benefits that DBS can offer are one, the substantial reduction of tremor that doesn't respond to medicine. And people will experience about a 70% reduction in tremor as a result of DBS. We expect that DBS is going to give you an increased number of hours of on time without troublesome dyskinesia throughout the day. And so it alleviates a lot of that unpredictability of response to medication that can be really can plague people that have Parkinson's. That many people will avoid social events, avoid going out, really be hesitant to do a number of things because they just can't be certain how they're going to be, how if their medications are going to kick in, and if their symptoms are going to be adequately controlled to the point where they're going to feel comfortable being out around friends or family or doing other things. And with the each of the modern DBS studies that have been done, they've include a quality of life measure, and there are improvements in quality of life that have been frequently reported in patients who have DBS. Of course, this is a brain surgery, and all surgery has risks. This, the way that this is performed would be considered a minimally invasive surgery. It is, considered, very safe, but nothing is with zero risk. And so the main things that we concern ourselves about are basically twofold. One is, we're opening up the brain cavity, the cranium. We're cutting that skin. There's always a risk for infection, and so we do our best to pre-treat with antibiotics, and obviously things are in sterile environments, but we are implanting a foreign body and a foreign object into the body, and so infection is a risk, and so that is something that we do worry about, or something that we do encounter. And sometimes requires removal of the system if infection does get out of control. And then the other is the risk for bleeding within the brain. We go to great lengths in the pre-surgical planning process to avoid any vessels, and to choose a path that's going to be as safe as possible. And I know the surgeon that I work with does a lot of pre-surgical planning to make sure that that doesn't happen, but nonetheless, that is, what is reported, that there can be a low risk. We're talking somewhere between 1% and 4% based on kind of where you're getting your data from, in terms of some bleeding within the brain. Listed here also is seizures, stroke, or changes in mood and vision. Seizures, really, I can say I've never actually seen that happen. It is reported. I think the instances in which that had occurred was when the DBS system itself had been turned on too soon after surgery. So we, in an effort to avoid any of that, the common practice these days is you have, the first surgery of lead implantation, and the system doesn't get turned on for about 4 weeks afterwards. And when you come into office to see your neurologist to do the initial programming of these devices. So what is the typical path that people take from, okay, you're interested in DBS, or someone has suggested that maybe you would be a candidate for DBS. You've listened to the presentation today and feel as though, oh, I have a number of those issues. I wonder if I might be a candidate. Well, the path starts with, between yourself and your neurologist, to have an evaluation and to determine if the symptoms that you're having, would be well responsive to DBS. We have this, 1-2, step here, that second step of have a DBS surgery evaluation. For me, that's really kind of multiple steps. And that includes having an appointment where you come in, having not taken your medication that day. We do a full, comprehensive Parkinson's evaluation and assessment, a full examination that generates a specific number score. And then we have you take your medication, and we see how much of a difference there is from being off medication to on medication. As I mentioned, we expect that symptom, what the benchmark that we use for expectations from DBS surgery is kind of the amount of responsiveness that you get from levodopa. And so we use that to make sure that doing the surgery is going to provide relief that we're looking for. That's going to, the pre-DBS evaluation also requires meeting with a neurosurgeon. It requires having a preoperative MRI. And sometimes, for almost all of my Parkinson's patients, will require something called neuropsychological testing, which will screen for dementia and making sure that if there's any problems with anxiety or depression, that mood can be optimized beforehand, and making sure everything's in a good place for us to set the stage for success with surgery. And then once those things have been completed, that leads us into the actual lead implantation surgery. That is what we refer to as stage 1. Some centers will even stage that and do one side of the brain followed by another side of the brain. Most of the people around in these parts will do both sides of the brain within the same surgery. That procedure then is followed 2 weeks later by the implantation of the IPG, the impulse generator, or implantable pulse generator, excuse me, which is that battery computer device that I had showed you a picture of earlier, and the connection between the lead that was previously implanted to that stimulator. And then 2 weeks after that step, after the stimulator implantation, is the initial programming and optimization phase. And this is, again, another one of those that is kind of a multi-step process within itself. There's the initial programming where you turn it on for the first time. We're exploring where, the benefits that it can provide, what the parameters are in there, where side effects might occur. And then, I generally think of that first visit of turning it on as being kind of finding that the rough focus within a camera, and then several other, short-term follow-ups with the neurologist to kind of get that fine focus and optimize things and kind of get things to the best place where they can be. The outcomes, have been, kind of validated now on multiple different occasions. There's a study here what was called the Intrepid trial, which looked specifically at the Boston Scientific device of this multiple independent constant current device that separately powers each of the electrodes and allows for what we call current steering. And you'll see a picture of that again, I think, in a moment here. And demonstrated that at a year, patients with DBS implantation versus those who were put in the control group without DBS had 6 hours plus a 3.8 hour increase in their on time without troublesome dyskinesia. So you get the difference, I believe, from, if I'm not mistaken, and perhaps JH or Jason can correct me, but it was the 3.8 hours of which was the difference from their baseline to their 12-month follow-up of improved on time without troublesome dyskinesia, which is substantial. When we look at the medications that we use to try to address a number of these same issues, we tend to run into like an hour and a half. 90 minutes is kind of like our ceiling for most of the medications to improve that on time without troublesome dyskinesia. So 3.8 hours is incredibly impressive as far as that's concerned. And so with Boston's Scientific's system in particular, there's a couple of different batteries. There's the rechargeable and non-rechargeable options. Both have a couple reasons to be used, and you can take a look at those here. They're both kind of have rounded contours and are very thin, and the kind of contoured design of this is appreciated, previously with, prior iterations of deep brain stimulators and the batteries. There was kind of squared edges that kind of cosmetically kind of poked out or caused some irritation for people. And so the kind of contoured edge does really make a difference. And there's been this rechargeable battery that has at least is FDA approved for 15 years and requires periodic charging, obviously. The benefits, there, as I said, there's benefits for each of them. The non-rechargeable has the convenience of, basically it goes in, you never have to think about it again. It's on, it's always on, and so you don't have to think about, oh, it's time to recharge my battery. It's just always going to be there, always going to be providing therapy. And depending on settings and therapy, that it may need to be replaced in a shorter time span than the non-rechargeable battery. The rechargeable, battery is a little bit smaller, is a little bit thinner than the non-rechargeable counterpart. And will require fewer replacements of the battery, given its 15-year lifespan. So, for many of my patients, they may get one of these and never have to have a battery replacement again. So it's really kind of just depends, and it's certainly the vast improvement upon prior iterations of rechargeable batteries. A frequent question that I get when talking to people initially about potentially getting DBS is, well, what if I need an MRI in the future? And all the Vercise genus IPGs, these batteries are MR conditional, and so you can have MRIs while having the DBS in place. And the leads themselves, you can see kind of a cross-sectional diagram of this. Basically, the take home here is that they've been built to be incredibly robust and durable. To my knowledge, I've never seen and I can say personally for any of the patients that I've cared for, never seen a lead fracture with one of these particular lead extensions. So, that used to be something that we would worry about, especially as as people continue to progress. And may have a fall or two that we might have to worry about damaging the system, damaging the lead, and that those concerns have been significantly reduced with the construction of the Boston DBS leads, or the extensions, I should say, and the leads. There are a couple of targets that we use for targeting in the DBS system in Parkinson's disease. That includes the globus pallidus and the subthalamic nucleus. Most people around, I think there's a favoritism towards the subthalamic nucleus, but both provide good relief, and there would be potential reasons to choose one over the other, and it's really, again, a patient-specific type of decision that's made between patient, neurologist, and neurosurgeon. And important notes, here the subthalamic nucleus itself is incredibly small. It's about the size of an almond, and the kind of motor portion that we're aiming for is about occupies about a quarter of that. And so there is a lot of prep work that is required before surgery to make sure that we can get the lead into the place where we want it. And so part of the reason for bringing that up is to highlight how small that target is. And with the modern DBS products, they have something that's called current steering, and specifically with the Boston Scientific device, each of the segments within the lead can be turned on independently to really precisely control where we're putting that electrical field, so that if we're off by just a little bit, if within the OR we miss our target by a millimeter and a half, that we can redirect that current away from the center axis of the electrode and put it back exactly where it's supposed to be in that subthalamic nucleus, or within the globus pallidus. And so it's much more than these prior systems, the older kind of archetypes of DBS, where you kind of could turn the system on and off. and this really allows for, gradation and very precise control of what the electricity is doing. Allows us to shape that electrical field exactly where we want it within the brain. This here, there is, obviously a long-standing history of people getting DBS within the country. It's been approved since the early 2000s by the FDA in the setting of Parkinson's disease. There are a number of people with some other systems in place, and there are these adapters that allow for the use of these rechargeable batteries for people who may not have a Boston Scientific lead. I certainly have had patients that have gone this route before. I'll say, maybe on a personal note, when able, I tend not to like to mix systems because we kind of lose the MRI capabilities and approval when we start doing that. There are certainly, patients who have, burned through a bunch of batteries, didn't have a good response to other rechargeable batteries. And so, certainly the rechargeable system here is an upgrade, and it works very, very well. And so, the way that the rechargeable system goes is, that you have a charger that sits on a cradle that charges itself up. You place that within a collar that goes around your neck, and that it gets placed directly over that battery, that IPG, and that charges it up. That can be done as infrequently as once a month. I say most of my patients do this probably once a week to top it off. They put it on, they sit in front of the television, watch a program or two, and then that's it. And then that's all they have to think about then for the rest of the week. I've got a couple of patients that prefer to take 5-10 minutes and top it off every day or every couple of days. But I'd say by and large the most common pattern is people will choose a day of the week, sit down in front of the TV or doing some other hobby, and charge up that battery. This is what the kind of patient programmer end of things looks like. Each patient with DBS gets their own ability to communicate with a neurostimulator, which provides a more limited ability to make some adjustments. That you can check how your battery level with it, adjust stimulation within the parameters that your neurologist has given to you, if any, and is able to turn the stimulation entirely off and turn it back on again. And there are a number of resources that are available online in DBS and on the Boston Scientific website. And this includes all sorts of informational, a pamphlet type of things to learn more about this. It has a quiz, to determine if you think you might be a candidate for DBS. There are a number of videos and other downloadable resources, testimonials and other patient stories. And then there's also the ability to speak with some of the DBS patient ambassadors. These are people who are patients who have had these systems put in themselves, and they are around to talk about what their experience was, with Parkinson's disease, what their experience was with the surgery, what their experience was after the fact, and really to kind of give a real world, real life, and personal account of someone who actually has Parkinson's disease, who actually went through one of these procedures. And I think that when I've spoken to these people before, a common thing that I hear is, gosh, I wish I would have known about this earlier. I wish I would have done this sooner. We'd talked about it for a couple of years, and I delayed it for a little while, and gosh, it really made all the world of difference. So for people who are properly chosen, for those who are good candidates, it is an incredibly powerful therapy that has become part of the standard of care in the setting of Parkinson's. So I realized that I kind of went a little bit longer than I thought it was going to take me, but that is kind of the end of the slides that I have. And if there's any questions, I'll be happy to address them now.
Thank you, Dr. Coleman. Folks, if you have a question, you can either put it in the chat or you just unmute yourself. You have that ability, and then go ahead and ask the question.
You still keep taking your medication while you got DBS?
That is a great question. So, and one that I didn't really touch upon. So thank you for that. So in the short answer is yes, yeah, you do continue to take medications after DBS. However, we are generally able to significantly reduce the amount of medications that are required. So on average, we're able to reduce the amount of medication that people need by about 50%.
Thank you.
You're welcome.
Okay, do we have another question? Unmute yourself. It's the little microphone. Just click on that and it will unmute if you have a question.
I don't know if you can hear me, but
We can hear you.
Okay, thank you. How long does DBS last? How long is it good for? I mean, to help symptoms.
Yeah, I mean, so we have, the data goes out, from the studies that we, conduct usually to a year or 5 years, but the DBS itself, the therapy itself, lasts far, far longer than that. And I would argue that it, basically goes on for as long as you have Parkinson's disease. That, this is the important thing for us to remember is that, this isn't a cure, it doesn't, this is still, we still are in search for a very, a good disease modifying therapy and treatment that will slow down the progression of Parkinson's disease. And so there will be, may continue to be, and likely will continue to be changes that occur over time. But, when patients of mine have said, you know what, I don't think this is doing anything for me anymore. And we've, gone through the, into the office and turned their system off, things generally get much worse. And so they aren't perfect, but certainly it continues to provide good, therapy and reduction of symptoms long term.
So if it stops working or is not effective, does it make sense to do the surgery over again and place the electrodes in a different location?
That's a good question. So the answer is maybe. So sometimes if people aren't getting the benefit that we think that they should, we may feel as though it may, the electrode is placed in a wrong location or is off target to some degree. And if we find that that's the case on imaging, then yes, we may, that may necessitate a revision surgery to put it in the right place. I've had, we've had a few patients along the way where for really kind of specific reasons, we have chosen to put in, a third lead into a different target. Someone has Parkinson's disease and get two leads implanted into, the subthalamic nucleus, and they still have tremor that we're not, getting a full capture of. And, I've had someone that will then have it put into the thalamus. So, and those are pretty uncommon circumstances. So there are times when that may occur, but as a general rule, the answer, is, you get them in, if they're in the right place, there's not a need to have to do it over again.
Okay.
Did I answer your question? It was.
All right, thank you.
Okay. Do we have any other questions?
I'm going through the evaluation phase, and they're going to make a decision in a couple weeks.
Mm-hmm.
So the battery pack, does it stick out from your chest? Or is it flush with the chest or?
It's, you can feel it, and depending on which battery you get placed, they have different, profiles, and it kind of depends also on your specific body type. Some people, who are really thin, it does stick out a little bit more. It is placed underneath the skin, and so it may be able to be visible. For a lot of people, it's there, and you have to really kind of feel for it to see if it's there. So I'd say that if for someone who's looking for it, you probably can notice that it's there. But for the most part, those batteries have gotten smaller over time and much lower profile. But it is there. It is an object that goes underneath the skin, so you'll be able to feel it.
Right, but it's not a real noticeable. Doesn't stick out from your.
No, I mean, day to day, no one else would know that it's there.
Okay.
If that's what you're asking, even out at the beach, type of a thing, you very easily could go unnoticed.
Can anyone hear me?
Yes, we can hear you.
I have DVS and it's virtually unnoticeable.
Thank you. Thank you for sharing that. So your device is not noticeable? Is that what you're saying?
Yes, although the scar is.
Yeah, I mean, really the thing that used to be more of an issue was that, we place these leads, they usually tend to go right behind the hairline where the leads go. And they used to be kind of create some bumps that you could see for people, especially if you had a little bit of a receding hairline. But the newer devices now, even when I know they're there for my patients, I'm looking at it and you really can't tell.
Oh, the one step that in the surgery I didn't hear you mention, but I believe it would be part of it, is putting I call them anchors.
Yes. So I didn't go into quite as much detail there. But yes. So when we do the first stage, when we put in that lead, it requires the putting in what's called a burr hole, which is we drill a hole that's about the size of maybe a nickel or so, maybe a little bit smaller than that, and then there's a cap that gets put into in that over that hole that has a locking system to secure that lead in place so it doesn't go anywhere.
So that's usually like 1 week, 1 week before the surgery.
No, that's done. That's all done within that first stage, that stage 1 surgery. It's all done at the same time.
Okay.
One thing you should be aware of is that once you get the surgery done, continue to take your medicine. I didn't, and I was brought up by my doctor because I didn't need it. I felt that I did not need it.
Yeah, the amount that we're able to adjust medications varies from patient to patient. There's, as I said, we expect to be able to reduce it by about 50%. I've had some patients who are able to stop medication entirely. Those are those are fewer by a fairly significant degree. There's some where we're not able to quite make that much of a reduction, that we would expect from that 50%. So it really kind of falls all over the place, but the bulk of people that we try to change is kind of within that 50% ballpark.
Adam, you're with Boston Scientific, right?
I work for Beaumont, and I do I run the Parkinson's Disease and Movement Disorder Clinic there at Beaumont. I have a neurosurgeon that I work with, and we have implanted all sorts of devices. There are 3 main manufacturers. We've implanted them all.
Well, what's his name?
The surgeon?
Yes.
Dr. Stout, Mike Stout.
Okay.
There's also Dr. John, who works within the Beaumont system.
John did my surgery.
Yeah, he's done a lot of them. He's very, very experienced. He does most of his surgeries down in Dearborn, and so I don't see him around quite as much because I'm located in Royal Oak. Dr. Stout is newer to their program, and he's located at Royal Oak, and so we work pretty closely together.
Do you still install the Medtronics device that requires a new battery every 5 years?
I'm sorry, what was the question about the Medtronic batteries?
Yes. Do
Yeah.
you still install the Medtronics device that requires a new battery?
Oh, so we have done some. I think that, if I'm being honest, we've done much fewer of them in recent history than we did when they were the only option to choose from. And so everybody, now it's much more competitive, and so everybody's racing to make a lot of great improvements with the technology, which is is great for me, great for you guys, great for patients in particularly, to have some of that innovation and the force that particularly Boston Scientific has done a lot of work as far as that's concerned, and the other companies have as well. That's not to disparage anybody else, because but the fact that there's more than one game in town definitely kind of keeps that progress moving forward.
I initially had the Medtronics, and I had to have surgeries every 5 years to
Yeah, so
replace the battery.
but the rechargeable battery that Medtronic has had, I admit, I didn't particularly or personally like very much. It worked, but it was kind of temperamental, and so we used a lot of the non-rechargeable options. And depending on settings, depending on what kind of therapy and how much electricity we're delivering, yeah, I mean, I've had some patients that were burning through batteries every other year, every 3 years, and those were again exceptional cases, but others that will last out to 6 or 7 years. It really depends on the patient and kind of what you're acquiring. It will last longer if you have one battery with one lead for whatever reason. If you only had one side that was done, it's there's a lot of variables that go into how long that battery will last.
From your experience, how long will Boston Scientific Rechargeable last?
Well, okay, so they're FDA approved for 15 years. That story is a little bit different over in Europe, and so there's some reason to expect that it may last longer than that, but we don't know. It hasn't been available in the United States for that long, so I guess time will tell. But there's no reason to suspect otherwise. So we expect that minimum it's going to be good for 15 years. Assuming that everything is working appropriately.
Okay, folks, we have time for one more question. Is there another question?
I had a question about dyskinesia.
Go ahead, George. Go ahead.
Thank you. I had a question about dyskinesia. This will help to improve it. Is that by taking less medicine?
That's a
probably.
great question.
Probably. So it depends a little bit. The most common target that's chosen in Parkinson's disease is subthalamic nucleus, and the way that dyskinesia is reduced by that surgical target is mostly from medication reduction. The other target that we use in Parkinson's disease is the globus pallidus. And the thinking there is that the actual stimulation of that brain structure reduces dyskinesia in and of itself. So we kind of get to the same place with both of them, but they kind of achieve it in slightly different ways.
That's good to hear. Thank you.
Mm-hmm.
Okay, folks, we are going to wrap up for this evening. I want to thank you all for joining us. And Dr. Coleman, thank you for an excellent presentation. Thank you, Boston Scientific, for sponsoring this program. We did record it. For those of you who want to review any of the information, we will have it posted on our YouTube channel, which is located on the homepage of our website. And with that, I'm going to say good evening, and we'll see you next week. Remember, you all heard what Dr. Coleman said about exercise being most important, very, very important. 10 a.m. Monday through Saturday, Michigan Parkinson Foundation has exercise on Zoom. It's an hour-long program, focuses on dual task training. So check us out if you have not already done that. All right, folks, good night.
Thanks, everybody. All right.
And thanks for putting
Thanks,
this
Dr.
on.
Coleman.
All right. You're welcome.
All
Right.
right,
Right, bye.
bye, all.